Hello friends, welcome to PGI question discussion series number 3. The first question is chronic vomiting leads to all except hyponatremia, hypokalemia, metabolic alkalosis, metabolic acidosis and hypokalemia. The answer of this question is metabolic acidosis. Now why this is the answer, why this doesn't happen, let's learn the basic concept. Now again we look at the options. As the patient is having lot of vomiting, chronic vomiting, the person is losing hydrochloric acid. So that means there is loss of chloride will be there. That's the reason why these patients will be having hypokalemia. At the same time, as the patient is losing hydrogen ion also, that will lead to metabolic alkalosis. Patient is vomiting and it will be losing sodium also. So this is how these three things will happen. This we can simply explain by loss of gastric content in the vomitus, losing sodium and HCl. But why this hypokalemia occurs? For that we have to learn the basic concept. The basic concept goes like this. As the body is losing lot of sodium, so now what happened? This is the glomerulus. Now this large amount of sodium come to collecting tubule and DCT. Already body has hyponatremia and sodium is one of the most precious ion for the body. Now body will try to conserve as much sodium as possible. So now let's learn what happened in normal physiology. In the normal physiology we have a aldosterone which come and act on the distal part of DCT and the collecting tubule, and normally it absorbs 2 sodium, and as the 2 positive particles have been reabsorbed, as per law of electrostat, body has to excrete 2 positive particles. So 1 H ion and 1 potassium goes out normally. Now as the patient has severe hyponatremia due to vomiting, the body will try to secrete more and more aldosterone, and because body want to preserve sodium, so now amount of sodium absorbed is 4. Just for example, now 4 positive particles have been reabsorbed. As per law of electrostat, body has to secrete out 2 positive particles. Now body will be secreting double potassium and double H ion. Now double potassium goes out, that lead to hypokalemia, and H ion goes out, that further contribute to metabolic alkalosis. So hypokalemia occurs mainly due to tubular secretion, but as far as metabolic alkalosis come, it occurs due to loss of acid in the stomach due to vomiting, as well as loss of H ion in the tubule also. So both contribute to formation of metabolic alkalosis. Okay, so obviously metabolic acidosis will not happen. So now you are clear about it, why the answer of this question is D. Now what are the other effects of severe vomiting? Patient will be developing hypovolemic shock, obviously. What else? Because of alkalosis, patient may develop tetany also, because when the tetany occurs or due to alkalosis, the ionized calcium level is reduced, and that's the reason why tetany occurs due to vomiting. So a quick recap of what we can learn, that in case of chronic vomiting there will be metabolic alkalosis, hypokalemia, hypochloremia, and of course hyponatremia will happen. Question number 2. A 24-year male present with altered sensorium and rapid shallow breathing, ABG shows pH of 7.20. That means he has acidosis. Sodium is 140. that is normal, but bicarb is 10, low bicarb. Chloride is 98, fairly in the normal range. What is the most likely diagnosis? The answer of this question is DKA and ethylene glycol poisoning. Why? These are the answer. So for that, let's learn the basic concept about anion gap. Okay, how we really calculate the anion gap? Sodium minus chloride plus bicarbonate. But before I proceed further, in this equation I have taken only sodium. I have not taken consideration about potassium, because some of the books they write even as sodium. Anion gap is sodium plus chloride. They take sodium plus chloride. They add potassium also. But latest Harrison says only this formula. Since our examiner followed Harrison, so I am writing using this formula. Why I am saying? Because some of you may say, though I read in that book or in that Kunji they have taken sodium plus potassium. Don't take that. This is the best answer as per latest Harrison. So with this background of some removal of your confusion, 135 is sodium, chloride is 104, bicarb 24. I am taking average figure. We know very well bicarb is 22 to 28. Same thing, sodium is 135 to 145. So I have taken just a average for the general calculation. For this calculation, the anion gap come out to be 7. A normal anion gap is 6 to 12. So now if I ask you what is anion gap, because as per this calculation we are getting 7 extra positive particles, but we know very well that as per law of electrostat, positive and negative are equal everywhere. So it means we have certain extra, there are negative particles which are there, which we have not taken into consideration, like sulfate, albumin, phosphate, lactate, etc. So what is the anion gap? It is the measurement of unmeasured anions. Okay. With this background, we come to the table. What are the common causes of increase anion gap? Now if we calculate anion gap in this patient, anion gap is 140 minus 98 plus 10. This comes out to be 108. 108. So anion gap is 32. So we are getting increase anion gap in our question. So let's see what are the causes of various type of metabolic acidosis. So first of all, with increase anion gap, this is seen in lactic acidosis, DKA, prolonged starvation, renal failure, poisoning, salicylate, methanol or ethylene glycol poisoning. Normal anion gap is seen in renal tubular acidosis, diarrhea, interstitial nephritis, glue sniffing. Anion gap may be less than normal in multiple myeloma and hyperparathyroid. So now you are clear about it, that in the options this will have a normal anion gap and glue sniffing will have a normal anion gap, but the anion gap is increase in DKA, increase in ethylene glycol poisoning and increase in chronic renal failure. Okay. In this, sorry, E should also be there, it has typing error. CRF is also there. Okay, it was a typing error. Let's talk about question number 3. A 20-year-old male presented with sudden onset of respiratory distress with tachycardia. His BP is 90/60, loud P2. What is the true about this condition? D-dimer assay should be done, increased oxygen saturation is seen, S wave in L1 and Q wave in 3, low molecular weight heparin should be given, and IV steroid should be given. As per the history goes, this seemed to be a case of pulmonary embolism. The answer of this is ACE, D-dimer assay should be done, ECG finding in option C is correct, and low molecular weight heparin should be given. Okay, so let's learn more about pulmonary embolism. So first of all, this the clinical feature of pulmonary embolism depend on the number, size and distribution of emboli. Usually it is single one. Small emboli may be asymptomatic, large emboli may be rapidly fatal also. So that means presentation may be totally asymptomatic to rapidly fatal. Sudden death can be there, and fortunately 70% are asymptomatic. This question has come in NEET exam. But otherwise, if the patient has symptoms, sudden onset of dyspnea is the most common presenting symptom. Pain chest can occur, but remember, pain chest is never the presenting symptom. Pain chest is the presenting symptom in acute myocardial infarction. Hemoptysis can occur, dizziness and syncope can occur, and of course sudden death can occur. In the signs, pyrexia, cyanosis, tachypnea, tachycardia, hypotension, race, JVP, pleural effusion, and something very interesting not known to most of the students. This is a top rank getting question is this. Some of the patient may even have bradycardia also. What we call as paradoxical bradycardia is there. This is the top rank getting question. Now a question homework for you, and this question will fetch rank number 1 in various exams. The question is, in which condition we get paradoxical embolism? This is the homework for you. You answer this question at the to my personal WhatsApp number given at the end of this lecture. Okay, so we continue with pulmonary embolism. Just to again remind you, pulmonary embolism is one of the most frequently asked topic in all the exams throughout the world. So you will be also getting a question in your exam. So read this topic very carefully and repeatedly. So we continue. So there are certain extra points that you should know. As I told you, sudden dyspnea is the most common frequent presentation. Tachypnea is the most frequent sign. Chest pain is due to pulmonary infarction, and okay, so it is especially in those cases where the infarct is located to near the pleura. And of course, this is the most common cause of acute right heart failure. This was again latest question. Tachycardia is the most common feature, but sometimes there can be paradoxical bradycardia. There is a repeat point I am saying. Okay. Now what investigation we have? Chest X-ray may be normal, or it may show Westermarck sign, very frequently asked question, that is focal oligemia. We may also have dilated right descending pulmonary artery, so called Palla sign, wedge shaped opacity over diaphragm, so called Hampton hums, or sometimes small pleural effusion can be there. Now in the ECG, tachycardia is the most common. Bradycardia can occur, but otherwise typically S1, Q3, T3, you can see S wave in L1, Q wave and T inversion in L3. In the blood test, D-dimer assay is very sensitive test, okay, and sensitivity is as high as more than 95%. Now something more about the basic concept about D-dimer. Is a nothing but fibrin degradation product. Okay, elevation of D-dimer is indicate endogenous fibrinolytic process. D-dimer SR are highly sensitive for presence of thromboembolic disease, and it is used as a test for exclusion or rule out test, but it is not a diagnostic test. That means if D-dimer is not raised, then we can rule out it will be case of pulmonary embolism, okay, but it is not a confirmatory test. Now the second question number 4 is again related to pulmonary embolism and the prophylactic measure of deep vein thrombosis. Why? Because we know 70% of pulmonary embolism come from deep vein thrombus and 30% from pelvic vein. The prophylactic measure include warfarin, heparin, compressive stocking, pneumatic device or dextran. Okay, so answer is they include everything except dextran. All the answer mentioned here, they are a prophylactic measure. So let us see, we continue with our discussion on pulmonary embolism, how we treat a case of pulmonary embolism. We immediately start dabigatran, which is a direct thrombin inhibitor, and we can give rivaroxaban or apixaban, both are anti-factor 10A agent. We can give any of these anticoagulant. We can also use low molecular weight heparin or fondaparinux, which is again a factor 10 inhibitor. Okay, and if the patient has a recurrent problem, then we can even keep a vena cava filter as a so that the embolism does not reach right heart. But this again we use as in those cases as a prophylactic measure where recurrent problem is there. But traditionally what all we use as a preventive measure is early mobilization. Suppose patient has been operated, we want the patient for any reason patient should be made to walk as early as possible depending on what type of surgery is there. But even after prolonged bed rest which can induce deep vein thrombus, patient should be advised, even his patient on the rest, patient should keep on moving his leg so that there is a exercise of the calf muscles. We can use warfarin, heparin we can use for a prophylaxis in the initial days, okay, but otherwise graduated elastic compression stocking is done and pneumatic compression devices are there. Okay, so dextran is not used as a prophylactic measure. So last minute revision point about pulmonary embolism which have been taken from our medicine essence. The most common cause of acute right heart failure is massive pulmonary embolism. Most common symptom of acute pulmonary embolism is sudden onset of dyspnea. In acute pulmonary embolism, the most frequent ECG finding is sinus tachycardia. Okay, D-dimer is very useful diagnostic test for pulmonary embolism. It is test to rule out pulmonary embolism. Best investigation is CT angiography. Maternal sign is seen in pulmonary embolism as in echocardiography, and Kazan disease can lead to gas embolism. Question number 5. Increased PT is seen with warfarin therapy, liver disease, factor 8 or factor 9 deficiency or vitamin K deficiency. So it is seen in warfarin therapy, liver disease and vitamin K deficiency. So before I discuss this question, let us learn the basic concept about the process of clotting. So we have an intrinsic pathway and we have an extensive pathway. This is one table which we read in our first professional, rather when we enter the medical college, within a few days this table is taught to us. Now let us see what happened. So the initial clotting factors in the intrinsic pathways started from prekallikrein and low molecular weight kinogen. It is not H, it is K. K is kinogen, low molecular weight kinogen. they convert factor 12 into 12a, and this 11 into 11a, 9 9a, and 9 finally with the help of 8 convert 10 into 10a. Now if any problem occurs in anywhere of this causes prolonged PTT. That means prolonged PTT will happen with the factor 12, 11, 9, 8, and of course calcium. Now let us see what happened in extrinsic pathway. Factor 7, it is converted into 7a, and this again is what convert 10 into 10a. The common path for both is 10 into 10a. Now any problem in here will lead to prolonged prothrombin time. That's why factor 7 deficiency will lead to prolonged prothrombin time. And one more thing, vitamin K dependent factor are factor 10, 9, 7, 2. 10, 9, 7, 2, 1972, just a mnemonic, right. So they are vitamin K factor, and vitamin K is synthesized in the liver. So factor 7 is the one which is concerned with extrinsic pathway, and any problem in factor 7 will lead to prolonged prothrombin time. Next point, factor 7 has the shortest half-life. That's why prothrombin time is always the first to get deranged in any acute liver disease. So only factor 7 problem will lead to prolonged PT, and all what I told you was due to lead to a prolonged PTT. Point to be noted, factor 10 and 9 is here. So liver disease will lead to prolonged PTT also. Now factor 10 is converted to 10a. Any problem here, the 10a will convert prothrombin into thrombin. Thrombin will convert fibrinogen into fibrin monomer. Any problem here will lead to prolongation of both PT and PTT, and any problem here will lead to prolonged thrombin time. So I hope you have understood the concept of intrinsic extrinsic pathway, and where the only PTT will be prolonged, where the only PT will be prolonged, where both PT and PTT will be prolonged. Okay, with this background of understanding of subject, we move further. Isolated prolongation of PT will occur in vitamin K deficiency, warfarin therapy, liver disease, factor 7 deficiency, and newborn. So in these cases prolonged PT will happen, because ultimately in all these cases factor 7 is deficient. So a summary, PTT is prolonged with deficiency of 12, 11, 10, 9, 7, 2, 1 and thrombin. PT will be prolonged in 10, 7, 5, 2, 1 and thrombin, and a prolonged bleed time with normal platelet is definitely due to abnormality of platelet, von Willebrand factor or a fibrogenemia. Now PTT is prolonged with bleeding manifestation factor 8, 9, 11. Prolonged PTT without bleeding factor 12, precalculin and low molecular weight kinogen defect. These are again very frequently asked questions. So in this place, if some problem happen at this particular spot, PTT will be prolonged, but it will not be having much of the bleeding. But in other factors, the PTT will prolong with bleeding tendencies. So now a quick recap of the last minute revision point. Converging point of both pathway is factor 10. Factor 7 deficiency presented with only prolongation of PT. Platelet function is assessed by platelet addition test. A patient on aspirin will lead to prolonged bleeding time, but clotting time will be normal. Hemorrhagic disease of the newborn will lead to prolonged prothrombin time because of vitamin K deficiency, factor 7 deficiency. PT is most likely to increase in vitamin K deficiency. Well friends, in addition to what I taught you, we have something more for you. You can take advantage of these things also. For my undergraduate friends, we have a UG test series separate for all profs. But for all my friends who are intern and post intern and writing entrance exam, you must join our UG online test series. If you do this much, 90% question will be covered by this. Here we give explanatory answer as well as video discussion also. We are the only one who do all this. And our tests are prepared by the expert faculties. We have a champion live test series where you have to go to computer lab to see the actual feel of the exam. Okay, because unless you are tuned for all this thing, your performance will not be as good as what you are, which you can do. You have a great potential, but get yourself accustomed to exam by joining our champion live test series. We also have a USMLE step 2 we are launching. You must, each one of you must see this acid base. Why I say acid base is the one topic which is weak for most of us, but you listen to this lecture, you don't need to read anything else when you see this lecture of acid base. And we have books of all 19 subjects, and I am very happy to announce in the AIMS exam May 2018, 81 out of 200 questions were based on our LMRPs, and 20 topics came from the last 2 week discussion what we have done with you. All these books and other details you can see at our website, and these books are also available on Amazon and Flipkart. Regarding test series, again you have to visit our website. This is the mini Harrison summary of Harrison 19th edition for undergraduate. This question bank based on 19th edition Medicine Essence. One more information for all of you, I have recorded many lectures on acid base, many other topic also, various topics other than acid base also. You can see in our YouTube channel what is given here. In addition, you can very well join on my broadcast group. This number is given, okay, and you can send me your details and I will be sending you lots of updates. And one more information, once we finish PGI series, I will also do the JIPMER test discussion. So my best wishes to you for all the exam which are about to come, and if you need any guidance, I am there to help you out in the best possible way. Thank you very much for watching this video. Okay, thank you very much. And of course, I asked you one question on in which condition you get paradoxical embolism. Send me the answer at my WhatsApp. Thank you very much once again.